Okay, any questions, anything left over from our jump start? Everybody okay? Everybody's good? All right, great. All right, so now we're on. We're on to our introductory module. In our module, to begin, it's really an overview that's a very abbreviated version of what we just talked about. I think you can summarize in 2 sentences the data on outcomes. Just, I think it's nice for people to know that it's helpful and we have data. It's probably very nice. And this is all outlined in the manual. Again, clarifying that we've got these 3 goals. Knowledge and education is 1, skills, individual family skills is 2, and support and creating a social support network is the 3rd. The format and the guidelines, this is where you walk through with your group the structure of the group. We're going to give practice. That people can find ways to practice. That's going to help them develop their skills more and so forth, and encouraging them. It's also by preempting. It's also a situation where you can say, we're going to try to be aware that we have, say, 12 people in the group, and we want to make sure that there's time for everybody. So sometimes we might try to put a lid on things a little bit and create room for somebody else to talk, and then of course there'll be more opportunities in subsequent, later that day or in a subsequent week. Orienting people to that ahead of time will make it easier to nudge people later when you need to. Then we talk about orienting to emotions and emotion dysregulation, which I'll move on to in a second. We'll talk a lot about that here. Understanding emotion dysregulation and assumptions, some assumptions that we make about families and movement, and summarize the research. So that's what we're trying to do in this first module, which is typically not that long. Now, as Marie-Paul said, and others may have said as well, also in this first week, it's pretty much the case that people have a chance to talk a little bit about what got them to come to Family Connections, to say a little bit about their story, their situation, so we understand each other. You know, gee, I've got a daughter this age who's been going through this, and we've been doing this for so many years, and this is her current status. Or I've got a son who's this age, or my partner's doing this, you know. So we get to start to know each other a little bit. And so that's important. There needs to be some kind of opportunity to talk about that. A little bit like we did last night, but maybe a little more room to talk a little bit more about experiences, so that people can recognize, oh my goodness, you know, this is a place where I can get support, but also I hear other people's stories and say, wow, I'm not the only person who's been going through this. And time after time, family members tell us that that's very helpful to them. So there's not a terribly big agenda on the first meeting that has to be accomplished. Some of these orienting things don't take very long, and there's time for people to get to know each other a little bit as we then move into some skills. Yep. In the first week, yes, typically. Yeah. Right. Yeah. I don't, when we've done it, I think it's gone naturally pretty well. Sometimes, I think the first person or two who talk often set a standard that other people follow, for better or worse. I can't say that I've ever had the experience where people went on so long that it was too long, meaning that we didn't have time to do other things. But I don't know, folks, what do you do?
I usually give a sense of time. So I say, you know, given the number of people who are here today, if you can keep your comments for 5 minutes. And if you don't mind, if I see that you're going over a whole lot, I will just give you a quick reminder and I apologize in advance.
Yep. Yeah, exactly. Well, you're brave and bold to have 26 people. Most of our groups are going to be more in the 8 to 12 range.
Here in the New York area.
Yeah, there's such demand, yeah.
It's so hard to say no when
Right.
someone calls you and you know, it's
Yep. Oh,
So we control that, and then we break them up into small groups in the activity where they really can, we give them a goal and an activity, something that they need to talk about, and then we can kind of open up and do that just before snack break time, so they can continue the conversation if everybody's in here, they can continue the conversation during the snacking break, and then they get to elaborate their story. Otherwise, that's the entire first 2 hours.
great.
They have to-
Yep, absolutely. I do want to add that these folks really are extremely good at doing this, and I want to discourage anybody from trying to have a group that big, at least in the beginning, okay? Later on, when you're facile with this and you want to do it, you're empowered to do it as you want, and I think you do a great job. But I think, would you agree that the first time that we probably keeping it in the 8 to 12 range is plenty? So, and if you want to keep it in the 8 to 12 range forever, that's also fine, you know. The geese agree. All right, so assumptions. Now, assumptions are interesting. Why do we make assumptions about anything? Why do we make assumptions that the planet will still be here tomorrow, for example? Or assumptions that I'll still have a job next year. That's not necessarily true in my state, right? To allay fear, yeah. How so? How does that help allay fear? Yeah. You make the assumption so that you aren't fearful about what might happen, might not happen, right? Like I assume that I will be here tomorrow. You're assuming that I'll be here tomorrow. Of course, I could get hit by the shuttle bus, you know. I'm not planning on it, okay? And I'm not suicidal, okay? So there's nothing like that. But it could happen, right? So, but and I think you're exactly right that if we don't make the assumption, we can get stuck not knowing and being very afraid of what might happen. We get immobilized, in fact. I think this is actually a huge thing that happens when we have difficulties in life, because it challenges our assumptions, okay? But I want to point out that assumptions are not facts. Assumptions about the future are not facts. There is nothing about the future that it's a fact. Nothing, absolutely nothing. There are facts in the past, and there is the experience of the present moment, and there are thoughts and assumptions and worries about the future. And they're different, they're really different. If we don't make assumptions, we get stuck worrying. I think you're exactly right. And it's not just worrying, we also get stuck arguing, right? What if we had to decide, well, do we come here tomorrow? Is there going to be a planet tomorrow? Will I get hit by the shuttle bus? We could spend a lot of time thinking about that, and then we could have a difference of opinion. Some people, no, of course he's not going to get hit by a shuttle bus. I managed to be, almost 53 and I haven't got hit by a shuttle bus. Yes, I'm pretty good at not getting hit by shuttle buses. Let's really hope this doesn't happen, okay? So, but then somebody else says, well, but 70,000 people die in car accidents every year. Who's to say that, this won't be one tomorrow? That's a fact, possibly one that challenges the assumption. And now we're stuck. Well, do you come tomorrow or not? Am I going to be here or not? What a mess, So we make assumptions because they keep us moving. And the idea is to make assumptions that are helpful and useful, not contradicted by science, by fact, and by logic. But assumptions aren't logical or illogical. They're assumptions. We make assumptions. Yeah. By the way, our assumption that I'm going to be here, or that any of us is going to be here tomorrow, that assumption at some point will fail, right? Once for each of us, okay, at some point. But okay, so we're going to make some assumptions in family connections that actually we think is very useful at helping us start to get unstuck from old patterns that help us maybe move forward in our lives. These are not meant to be statements of fact at all. They may be facts sometimes, but they aren't meant to be facts. They're meant to be things that we can actively assume and act as though. That's what an assumption does. It's an act as though. If I assume, if I make a plane reservation to go someplace, I can assume, unless I get a text message from the airline that says the plane is delayed or been canceled or salud, or if I know that there's some sort of problem, with a strike, in the news, I could assume that when I show up, I've got a seat. That doesn't turn out to always be true, by the way, in my experience. But if I don't assume it, I don't know whether to go to the airport or not. But if I assume it, I go to the airport, and almost all the time, 99% of the time, there is a seat for me, and often late, but I get where I'm going, okay? Does that make sense? So these are assumptions that allow us to do the effective thing that's likely to be most effective. And so we don't need to argue about whether they're facts, because we're not claiming them to be facts. We're claiming them to be useful things to act as though, okay? So one of them is to adopt a dialectical worldview. Now this obviously comes from dialectical behavior therapy, but I would argue that even if DBT weren't relevant here, this would be very effective for families. And in fact, there are many kinds of family therapy that have long pre-existed DBT that actually utilize a dialectical worldview. And that means that there isn't any absolute truth about behavior or experience. Okay, that means that we each have experiences that are relevant in a relationship, and that our explanations for why we do things are just that. They're explanations. They aren't true. There's no absolute truth about it. So if I think, the reason you're late is because you just want to piss me off, okay? Well, is that possible? It's possible. It's also possible that you're late because you're distracted and struggling with, you're late to all kinds of things, and I'm just one of those things. It's another possibility. That might be your experience. Of course, my experience might be different from yours because you're often late with me, but I don't see that you're often late with other people. Okay? Now that's just one way that makes it easier for me to assume that maybe that there are just different possibilities here. Now, that assumption that you're doing this to make me angry or to upset me or to mess with me, that's going to violate our second assumption that people are doing the best that they can, that we all are doing the best that we can, whether the person is a patient or a family member or a professional, that actually even when we're messing up in a big way, we're still doing the best we can. Is that true, by the way? Do we always do the best we can? Right? Anybody ever been like a little slovenly, a little lazy? Never. Right. Of course not. Yeah, well, I would probably say not never and not always, but sometimes, right? And the idea with that is that, of course there's another way to say, well, the best we can today might be different than the best we can tomorrow. And so maybe I was doing the best I could today. Maybe, not getting up and exercising is the best I can do today because I'm really tired. Maybe that is the best I can do today. But tomorrow, not having exercise today, I do get up and exercise, even though I'm just as tired. But the context of not having done it for a couple of days provides more motivation. So maybe it was the best I could when I didn't, even though I could do it differently in a different. Now that's just, but let's not argue about that. Let's just assume that we're doing the best we can, because otherwise, what do? We get judgmental and blaming, and we see it as a character fault of laziness and lack of motivation instead of curiosity. What's getting in the way? You see the difference? I mean, imagine that you're late to something, okay? Imagine that, I don't know, we're having our first Family Connections meeting on Tuesday, and you come late. And I'm the Family Connections leader, and I'm not making this assumption that you're doing the best you can. Then I can simply think, you didn't try very hard to get here. You're not doing the best you can. You're not very motivated. If that's the problem, what has to change? Your character. That's not so easy to do by next Tuesday, okay? Whereas if I'm interested, I say, well, this is the best you can, but you're also, 10 minutes late. That means you're 10 minutes. So what, and let's, I wouldn't, wouldn't even occur to me to ask you anything about it if you were 10 minutes late. But if you were 10 minutes late every time, say, what, notice you come in late. What gets in the way of coming on time? What happens? And it could be that, you can't get out of work. It could be that your babysitter doesn't show up. It could be that there's more traffic. It could be that you need a ride, and your ride is unreliable. It could be that you're overwhelmed with all kinds of other things. I mean, who knows what gets in the way? But me being interested in what gets in the way is very different than thinking you're a lazy sloth, Very different places we go. So the assumption helps us, notice, have different emotion. You come in, I have the emotion of interest and curiosity and of the possibility of compassion instead of, well, the problem is characterologically that, you're just not trying very hard. My emotion about you is really different then. See the difference? Can you feel the difference? Yeah. So this is an assumption. Again, could it be true that somebody's not trying very hard, doing the best he or she can? Sure. But let's not assume that. Let's assume the other. We also say, this is an interesting thing to pair it with, we also say that we all have to do better. We have to try harder. Okay, well that's true. We have goals. Until something's exactly the way we want it to be, we've got to try harder and do better, right? And because we're all dealing with, the reason we're here is because somebody in our life is suffering enormously, in addition to us, okay? Something isn't exactly as we want it to be, so we have to do better, try harder. And we're doing the best we can. Does that tweak anybody? Anybody see those as like, okay, now that's the dialectical worldview. I just want to point out they're both true, even though at first glance they might be opposite. But I want to come back to time. This is, again, these are assumptions. They're not meant to be truthful or factual. But if you think of them as though, you've also got to have a plausible way of doing that. So here's a plausible way of hanging on to both of these at the same time. Person's doing the best he or she can, right? As good as the person can do right now, based on everything that's led up to the person's life. But in the future, we want it to be different and be better. Now they don't seem so incompatible anymore if you put them if you don't make them overlapping in time, right? So if you see me skiing, okay, in Reno, we're on the eastern slope of the Sierra Nevada mountains, and so there's good skiing, everywhere around, very close. So if you see me skiing down the slope, you look up, you're sitting, at the lodge, and you see me coming down, and I'm zipping along down this trail and going kind of fast, and you can tell that I look happy when I come to a crisp stop at the bottom, and I don't take anybody out on the way down the slope. You could think, oh, he's a competent skier. At least, let's say it's not the most complicated slope, but an intermediate slope, and you see me, blah, 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 blah. Okay, say, well, he's a competent skier, minimally competent skier, and enjoys skiing. And then later that day, a couple hours later, you see me coming down the same slope, okay, and I'm falling down, and I get up, and I fall down, and I almost take somebody else down with me, and I get to the bottom, and I don't look happy at all, and I chuck my skis into the snowbank and walk away, okay? You could conclude that I'm not trying very hard, right? Not very empathic of you, but you could conclude it, right? You could think he's not trying very hard. He's not doing the best he can. Or you could be interested. What happened? Right? Now, in my experience as a skier, what happens is, by the end of the day, I'm pretty tired. And at my age, I can't sustain 100% for 6 hours of skiing. So when I start to fall down, I actually don't keep going. I end it for the day. That's number one. Number two, by the afternoon, when the temperature's just below freezing in the morning and the afternoon it's just above freezing, things get very slippery. And my skis have the kind of wax that doesn't do very well when you actually have moisture on the, actually water instead of snow, and actually it gets a little sticky. Anybody ski, you know what I'm talking about? Yeah? And actually, I don't like that. And that stickiness, I'm not used to that. I prefer, usually have pretty good snow. And when it's sticky, I fall down. It happens, okay? And it's not much fun. I probably wouldn't chuck my skis because I like my skis, but, that would not be much fun. And that would almost certainly be the last run of my day, and I want it to get cold and I'd come back tomorrow. Does that make sense? So there's that, now, but you approach it with curiosity. Gee, how come that didn't look very good? That looked much more fun an hour ago. How come that curiosity, that interest could lead to empathy and conversation and support that, gee, he's not trying very hard. I wonder why he wants to fall down. I wonder why he wants to knock other people down. You see, now, this is a silly example in a way, but what about when somebody's suicidal? Yesterday, the person wasn't suicidal. Yesterday something happened and the person handled it pretty well, didn't get suicidal. Today, something that doesn't seem to us to be even as big happened and the person is now suicidal. Guess you're not trying very hard, huh? See, it's exactly the same thing. Not trying very hard creates distance. It pushes the other person away. We're not interested in the person's experience. We've judged the experience. We've judged the person instead of persons, if we make the assumption. See, if that's the best you can do, and the best you could do was different yesterday, what's different? That's the logical question. That's interest. That's a different emotion. Curiosity. Curiosity is the fundamental and absolutely fundamental enemy of judgments and anger. Right? Try to be genuinely interested in something when you're angry. If you can find the interest, what happens to your anger? Poof, it's gone. It just disappears because they're incompatible emotions. So you're going to hear me say a lot today and tomorrow, if we can find some curiosity, if we can find some interest, that might be a transitional way to finding a way to understand, which is the way to get to validation. Whereas not being interested, being judgmental leads to closed-mindedness, leads to anger, and a recapitulation and a repeat over and over of whatever the dysfunction is. Because if somebody's suicidal or self-harming, there's a good reason for it. And if the person had the skill to manage that situation at a different time and doesn't now, we're assuming that something's getting in the way, something's different. And we don't have to know what that is. It's an assumption. And if we make that assumption, we can approach the situation and the person with interest and possibly with compassion, which is then going to actually be good for us too. Okay? And if there's no other reason to do it for yourself. By the way, that's a very good reason to do it. Okay. Now, sometimes, now I would argue, this one says benign interpretations are legitimate and effective. I would actually say that, and we struggle with this, my preferred assumption would be no interpretations are true. Okay? So in other words, the fewer interpretations we make, the better off we are. By the way, I think that's true in our life in general. Interpretations are, in our head, constructing explanations about why somebody did something. That's an interpretation. So if you've got two little kids, right, one clobbers the other with a toy. Anybody ever have this happen in your family? Yeah. And then you say to the 5-year-old, you say, why did you hit your brother or sister with the toy? Right, why, the why question? What does the kid say? Huh? Yeah, he or she started it, made me mad, right? I wanted the toy, okay? And we accept that somehow as an answer, okay? If the child, I want to point out, if the child said, in my history with you, and with my sibling, I have found that when I use aggression, I get what I want immediately. And so I found that when I really want something and other means to get what I want fail, aggression's pretty successful. And the costs to me are pretty small. You rarely do more than talk to me about it. And I still got the toy. So I found that I've been significantly reinforced for my aggression. Okay? Now, I think you would immediately take your child to a hospital. Okay, there's something wrong with the child. Now, I got to point out, that's actually, right or wrong, at least that's got some substance to it than like, she made me mad. Okay, well, like, if you accept that, now I understand why you clobbered the kid with the toy. You know what? We'd be clobbering each other all the time if every time somebody made us mad, okay, which really, all that means, by the way, is I was angry in your presence, okay? If every time that happened, we would have an even more violent and aggressive society. So there must be more to it than that. Now, rather than trying to come up with that kind of an explanation, which takes time, let's just assume that either we don't make interpretations at all, or if we've got to make them, Let's make ones that are benign, that don't assume the worst of the other person. So if you're late, maybe if I have to make an assumption at all, let me assume that you were trying really hard and something got in the way, instead of you're a really evil person and trying to disrupt the group. Do you see the difference? Now, I guess I don't know what an evil person is, but you could, I suppose it's conceivable, someone actually could intentionally come late to disrupt the group. In my experience, I think that's very unlikely as a fact, but as an interpretation, it's caustic, right? It does a lot of damage. So we're going to try to make interpretations that are both legitimate and more effective, meaning more benign. Okay. And we also assume that in families working together, or at least in parallel, some ways that are synchronous, that are at least towards the same goals, it's more effective than working at cross purposes. I don't think that's so controversial, but it's still important. I think that one's probably almost always true, but even when it's not, it's probably more effective to make that as an assumption. Okay, you okay with these assumptions? Now in your group, you might have to stop and chat about these. So I'm happy to stop and chat if there are questions or comments. We can do that. In some groups, this is pretty quick. People get it and they run with it. And other times, you stop and talk about several of these, and that's fine. But any questions or comments, or anybody struggle with being able to make any of these assumptions? Again, it's easier if you remember. No, I'm not saying it's true in this situation. I'm simply saying it's effective to assume it, to move on. I'm sorry, where's our microphone? Oh. Yeah, we do. That's right. Repetitive things, repetitive behaviors, especially ones that we don't like, that elicit negative emotion, it gets harder and harder and harder to hang on to these assumptions, in particular the benign ones. I think that's exactly right. Okay.
I just wanted to say, he was talking about someone who was late. I talk about how I feel and how what you're thinking. And I say it really concerns me that we can keep up to date if not all the people are here. So I'm talking about how the person feels instead of the person who's coming.
Right.
And I don't think it's good to use you because you are put people on defensive immediately. You've got in your corner and you use that. That's my opinion.
Right. Now, I don't want to get stuck on the lateness part, but I think that in family connections, people are late, they're late. They miss something, they miss something. We don't stop and go back for them, recover stuff, because that would be disruptive. This way, if somebody comes late, it doesn't disrupt anybody else. They've missed something. And so we don't have to do a you or an I. We can have interest. That's the emotion we're looking for, is interest and curiosity, and maybe disappointment, like that you missed something, but not criticism, judgment, or blame, which gets negative emotion. We want to welcome them to the group. We want to welcome them. Of course, we don't want people coming in and being disruptive, but I don't think that happens very often. But people do come late. That's ordinary, and we don't want to encourage it, but we also don't want to make any kind of a big deal out of it. You know, life is full of stuff, and you know, we do the best we can. That's our assumption. Okay, so that's the first module. So there aren't huge, lofty education goals in this first module. It doesn't typically take very long. It's usually 1 week or maybe 2 weeks. That's all. 1 or 2 meetings. And then we move into more substantive kinds of things. All right, and we call this the family education module. And what we're going to cover here is a lot about emotion, and emotion dysregulation, which we're going to get around. A little bit on research in the U.S. about emotion dysregulation, excuse me, and treatment. We're going to talk about expressed emotion, a very specific kind of thing, reciprocity and balance, and this idea of reciprocity, which I mentioned before, you know, what I do affects you, what you do affects me. And then we're going to talk about this transactional model, and I'll spend some time on that. The ones with the stars, I'm going to spend more time on it with slides. The others are more typically quicker, and they're in the manual. We won't spend a lot of time on them. And then a little bit on stigma, understanding the stigma that our loved ones feel. You know, there's a lot of stigma if you've made a suicide attempt, if you've been self-harming, if you're in the mental health system. And there's stigma being a family member or a partner of somebody in that. And that comes up in a variety of ways, and we'll talk a little about that. All right, so let's start with this idea of blank. So you've got this one on your handout. Maybe I'll co-use this a little bit. This one. So this is just a little diagram. In this model, we're suggesting that emotion dysregulation is the centerpiece of dysfunction, okay? And that around emotion dysregulation come things like impulsive behaviors, like suicide attempts, or aggression, low self-esteem, relationship problems, emotion about emotion, anxiety about being dysregulated, fear of having more emotion, despair about having emotions that are out of control, fears of abandonment that follow naturally from being dysregulated and having chaotic relationships, cognitive problems like trouble thinking straight, logically, doing good problem solving, because when emotion gets that big, nobody can think straight, judgments about ourselves, judgments about others, and all kinds of behaviors that people do to avoid those emotions or escape them that are dysfunctional. Really. There we go. Let's try that one. And the idea is that emotion dysregulation is the core of this. That emotion regulation drives these other problems on the periphery, and these other problems come back and drive emotion dysregulation. I'm a little bit incompetent on the PowerPoint, so I didn't know how to get these little lines to have arrows on them. But if I could have, each of those lines connecting the small circles to the big circles would have an arrow pointing in each direction, okay? Emotion dysregulation, being dysregulated leads to impulsivity, for example, and doing impulsive things creates more dysregulation, okay? These aren't controversial. I don't think there are very many mental health professionals who would disagree with this, okay? Having problems, being dysregulated creates problems in the relationship, and having a distressed relationship creates more dysregulation, right? Being dysregulated creates fears of abandonment, and being afraid of abandonment and having abandonment experiences creates more dysregulation. And we can do that all the way around the circle. So this is the idea. Now, again, I want to normalize emotion dysregulation in a way, because emotion dysregulation is something we all do. It's not something we have, it's something we do. And when we're not doing it, we're not doing it. When we're doing it, we're doing it, right? When we're dysregulated, we're dysregulated. When we're not dysregulated, we're not dysregulated. So there's no such thing as a dysregulated person. Everybody has the capacity for dysregulated emotion and dysregulated behavior. And everybody has the capacity for regulated emotion and regulated behavior. The difference between people at the psychologically healthier end of the spectrum and the psychologically more dysfunctional end is the frequency and intensity of the dysregulation. And that's just one way to understand that. Of course, there are other ways of understanding that. So if we're lucky, okay, and for a variety of reasons, temperamental and life circumstances, in other words, life treats us kindly, and we've got a solid temperament that matches well the life that we have, then we get dysregulated seldom, and it wreaks little havoc on our lives. So if once in a while you get dysregulated and you say something mean to someone you love, but it's the once in a while, which means that a few minutes later you're re-regulated, you do a little repair, and you don't repeat that a lot. There are chunks of time that are this big that you're actually a kind and decent partner or parent or friend, and then every once in a while you kind of blow it, and then you have this other period, and the other person blows it sometimes too. That's a pretty good life, right? I mean, this is a pretty good life. That's something anybody could be happy with, as opposed to flip it, and the periods of being regulated are relatively small, the periods of being dysregulated are relatively large. There isn't much time to do those repairs to other people or for ourselves before we're dysregulated again. In fact, the shortness of the regulated period contributes to getting dysregulated again. It's the anticipation contributes. So that's a harder life. That's the idea. So on the one hand, we're saying emotion dysregulation is really a normal process. It's just that sometimes it's so frequent and so intense, and the periods in between are so small and so infrequent that it characterizes our experience. And then that's when we tend to talk about a person being dysregulated. Of course, I just want to be clear, that's not literally true. A person is not. In the same way that, right, like you're all here, almost everybody's sitting down, okay, a couple people standing. If you're sitting, you're sitting. You're not standing, right? It's just, but you have the capacity to stand. It's in your repertoire. It didn't disappear, it's just you're not doing it. Emotion's the same way. When we have one emotion, we're not having another. When we're dysregulated, we're not regulated. When we're regulated, we're not dysregulated. It's something we're doing or not doing. So that lends itself to this idea that we want to meet people where they are, but recognize they won't be in that spot forever. Okay. Now, does that make sense just at a basic level? Everybody's had this experience of being dysregulated. Does it feel like that? Like, if you think about the last time you said you kind of snapped at somebody you love, you said something kind of mean, and you kind of snapped. What did that feel like? What did that moment feel like? Did it feel like a have to, like an urge, and not so much like a decision? Right? Like an impulsive act? Impulsive behavior comes out of dysregulated emotion. Now, I'm not saying it's the same thing in terms of its consequences, but snapping, saying something mean to someone we love is not different psychologically than trying to kill yourself or punching somebody else in the nose as an impulsive act that comes out of an urge as a reaction to the pain of the emotion in that moment. It's not really any different than if you have an electric stove, or you have even a pan on the stove, and the stove is on, even a gas stove. The pan gets hot and it's empty, and you didn't realize that you left the stove on, and you go to pick up the pan, and you just let it go. Right? That's it. We don't actually call that dysregulated, and the reason, you know why we don't call that dysregulated? Because it's useful. Because it's a really helpful activity. Right? That's actually like you're not burning yourself. You're not burning yourself. You're not hurting yourself. So the impulse comes out of avoiding pain. Okay? So, but the impulse to yell at somebody, be mean to somebody that you love, comes out of pain and avoiding pain. The impulse to kill yourself. People don't kill themselves on a good day. People don't hurt themselves on a good day. People don't relapse into drug use when they're having the best day they've had in weeks, right? They happen on the worst day, when they're feeling terrible, when they can't imagine feeling anything different than they're feeling now, okay? It's the same phenomenon as jumping back from a hot stove, okay? Now, it's a little more complicated because sometimes it's drawn out into more than a second. Sometimes it involves planning, like I'm going to kill myself tomorrow, and I'm going to kill myself in 3 months, so I'm going to stockpile medicine to do it. But that moment of decision comes out of that frying pan moment, and it's just that there's enough residual negative emotion to not get the person off the path that they're on. It's like inertia keeps them going until something kicks them off the path. So this is just a way of trying to understand it. The idea here is not that we're supposed to do anything for our loved ones based on this, except not take it personally as much. So if your loved one says you're a big jerk, that's still hurtful. It doesn't feel good, okay? I'm not suggesting that shouldn't hurt. I'm saying that there's extra suffering you can put on if you don't understand that that's coming out of the person's suffering and creating suffering in us, okay? But it's not only about hurting us. In fact, it's probably very little about, from the person's heart, about hurting us. It's probably much more like the moment when we say, you're a jerk to someone we love. It's not really, when we're regulated, we regret that. We know that's hurtful to the other person. We wish we hadn't done it. But at that moment, it actually seemed right. It seemed like the other person was a jerk. We weren't seeing past, we weren't seeing what was behind their current behavior. We weren't seeing behind it. We were only feeling our own pain, our own, which totally makes sense. It's just, it keeps things going. You okay with this? Is this all right? Okay? Because I'm trying to do two things that might seem contradictory. I'm trying to, on the one hand, normalize our family members' behavior in one sense, but also pointing out how it's extraordinarily more frequent and more painful than ordinary. So it's normal in one way and not normal in another. Okay? Not normal in terms of it's perfectly normal in terms of that small process. It's not normal in terms of the frequency and intensity. It's kind of got a life of its own. All right. Now, there are lots of treatments for these problems. And there's lots of debate about treatment. And I just want to say that at NEA and in Family Connections, we're all about data. Okay? We're just about data. We actually are in favor of treatments that work. That's what we're in favor of. And we're not in favor of treatments that either don't work or we don't have data that they work. I'm absolutely certain that there are treatments in the world that work better than any of these that we are going to talk about. But they don't have a shred of data, and so we have no way to know that they work. And if those people don't conduct research, those treatments will die with the therapist because they're doing these probably extraordinarily wonderful things that they won't pass on to the rest of us because they won't write a book about it and test it and show us that it works better. And then the rest of the world doesn't benefit from it. And so we can't know. And there are also people who believe that what they're doing works better and it doesn't. Okay, let's be clear. That's true, right? And that's true not just in mental health, it's true in all kinds of things. Well, no, I'm pretty sure that this is working better. And actually when you find is, we call that, in psychology, we call that a bias. We actually call it a heuristic, okay, a bias, a systematic bias where we tend to select things from the world of experience that confirm our thinking about things. And this is just a human activity. We all do it. And that's why data are so important, because otherwise we bring our biases to what we do. Okay? And yeah. So anyway, for example, when I was learning DBT a long time ago, I hadn't learned other treatments to treat this set of problems. I'd never been trained in another method. I was a master's and doctoral student, and I worked in Marshall Hernandez's clinic, and I had never had other experiences as a therapist using other models to treat chronically suicidal, self-harming people. I hadn't. So I didn't have anything to compare it to. And my experience was that this was a really hard treatment and only somewhat effective, and probably nobody would ever do it. Until I looked at the data, and I realized the data were so much better than other treatments. Which led us to say at the time, and I think it's still true, it's probably the best lousy treatment that we have, right? Now, that's valid, right? The best lousy acknowledges both sides. It may be better than other things that it's been compared to, but it's still, there are lots of people who don't benefit from it. And by the way, DBT has improved. I mean, our outcomes with DBT in 2012 are much better and much more deep and long-lasting than they were 20 years ago. The treatment has improved, and I hope will continue to improve. This is also true of other treatments. I'm going to talk about DBT. We're also going to talk about mentalization and treatment as usual, the kind of thing that you get in any community as well as specialty treatment. So we're going to talk about this. Did somebody have a question? Yeah.
I think it will also be important to note that what we're talking about is that research, what's effective. The research on those forms of treatment are measured being particularly effective for self-harming behavior such as suicide and other forms of self-harm. On the other hand, if you
Mhm.
which are shown to have also by research, very good response rates in terms of emotion dysregulation. I think the research is about that DBT is what you're talking about, is in terms of reduction of self-harm, suicide, and
Yes, and I think it's a longer story. I don't know if we want to, if it's of interest to people, like, but I would say two things. One, I think that DBT and these treatments are in a different class because they're trying to treat a different set of patients. They're actually treating people with more severe problems. And I think it's hard to compare them to other treatments that are treating people with less severe problems. That's part A. And part B, as we develop better long-term treatment data, the trouble is in this country, in the United States, NIMH won't fund treatment studies where the treatment lasts more than a year. Okay? Now, some of you have loved ones. Imagine, some of you have loved ones who've done well in treatment. Did it take a year? Okay. I've been doing DBT for almost 25 years, and let's just take the last 5 years. Maybe I developed some minimal competence by now. Okay, so I got to say, in my clinic, my own patients in our clinic, actually we do a little better than the published data if we compare ourselves to the published data benchmarks. We don't do better than the published data in the first year of treatment, but we do better than the published data because we typically have people from 1.5 to 2.5 years. And we're not bound by National Institute of Mental Health telling us we have to stop treatment after a year. So, but what we find is, and I can show you the data if you're interested, like in our recent study, randomized trial, the average young adult, remember I told you about the 18 to 25, at the end of treatment was not depressed. Not just less depressed, the average person in the study was not depressed. Like, not just not clinically depressed, not meeting the diagnostic, but actually was scoring on the Beck Depression Inventory, which is what our standard, less than 10, which defines the person as not depressed, just not minor depressed, not medium, not depressed. And those are really good, and that's the average person, that's the mean, which means that probably only about a quarter of people in that treatment study were still depressed at the end. And so we're improving, that's part of it. But you're absolutely right, there are other treatments that treat overlapping problems and may also be very good for what I would say now are the people with medium problems of emotion dysregulation. I think you're absolutely right. But those are typically not the folks, the relatives of people in the room. I think they're in the much more, wouldn't you agree, more serious end of things, where a year of treatment isn't going to, and the other treatments for this medium group, a year of treatment is actually a lot of treatment. Good treatments work really well with people who are not so severe, often in 4 to 6 months, doesn't take 1.5 to 2.5 years or longer. So let me just summarize for you the data on these. And this is my best summary, and I don't claim to have a corner on being right about this, but but these are things that we're really careful about at NEA because we want to support the things that work. Now DBT is the 1,500-pound gorilla on the data block. Okay, there have been at least 30 randomized controlled trials of DBT. So there's just literally dozens of controlled trials and many dozens of open trials of DBT. About a third of those studies now, or almost half, are with your relatives, okay? They're with people with suicidality and self-harm, severe out-of-control behavior. Not medium severity, but very severe. About half of those studies, let's say. And they're very consistent in outcomes. And in all of those studies, nothing has been shown to be better than DBT. DBT in 90%, 95% of those studies, actually really all but 2, has been superior, and in 2 wasn't better than, but was just the same as the comparison treatment. So DBT has the best data. That doesn't mean it's the best treatment. I'm partial to DBT. I like DBT. I've been doing it a long time. But DBT does not mean it's the best treatment. I don't actually believe it's the best treatment. I believe that it's got the best data, and therefore that's a good reason to do it. We also know that nationally, internationally, about a third of people who get DBT won't benefit from it. About a third won't benefit. So this is hardly the beginning and end of treatment, okay? We've got to have other things. Now, some of that third is because the people don't like it and drop out, and some of that third is people like it and they stick with it, but then they don't get better within a year, okay? It's hard to know what would happen if we had 2 years of treatment. We've only really had 2 studies that were that long with severe folks, and those studies suggested that, in fact, improvements continue in the second year, and actually there's a pretty low relapse rate. So there's good data for DBT. It's very good compared to other things. The treatment with the second best data is called mentalization. It's developed, by the way, DBT is developed by Marshall Linehan at the University of Washington. The studies are started out as outpatient studies for women. Now there are studies with men, there are studies with teenagers, there are studies with older adults. They're not just from the US, but from abroad. They're all over the world, and they're not just outpatient, they're inpatient, they're residential, they're forensic. They're kind of across the mental health system map, and data to support each piece. There's no piece yet that has said, gee, DBT just doesn't work for these people. We don't know. Sure, that's true, but we haven't seen that yet. All right, so DBT is pretty solid. Mentalization is developed by Anthony Bateman, Peter Fonagy in London, University College London. It's taken off pretty well. Because it's grown up in Europe, they've actually been able to do longer-term studies. The first treatment study they published is actually a 3-year-long treatment study, 1.5 years of daily treatment, intensive daily outpatient treatment, and 1.5 years of intensive, but not as intensive outpatient, twice a week outpatient. So 3 years of treatment, very severe patients, very good results, with excellent long-term results showing very little relapse. It's absolutely impossible to compare mentalization to DBT because they have not been compared in the same patients. I'm not sure that we'd actually benefit from doing it. It's pretty clear mentalization is a decent treatment. It's very clear DBT is. What mentalization is lacking right now are any studies conducted by people other than Bateman and Fonagy. So there's this little potential bias. In psychology, we have this rule. We say we only call something empirically supported or evidence-based if it has several randomized trials, and at least one of them was conducted by somebody who didn't develop the treatment. Okay? And mentalization doesn't quite yet meet that standard, although there are a couple studies going on by other people. I'm almost certain that it will. Okay? So, and mentalization, I want to say to those of you who are relatives, mentalization is respectful of people, and that's important. It doesn't treat people badly. And I'm not going to mention treatments that I think do treat people badly because they're not on this list. But there are some out there that I think are extremely pejorative and judgmental about patients. And they aren't on this list because they don't have good data. Either they've been shown not to work very well in one case, or they don't have data in other cases. So I don't want to be critical and nasty, so I'm not going to mention them, but they're not on this list. Yeah? Yeah. Yeah. It's an outpatient program, yeah. Well, this is of course, I want to be clear, that's not the... Yeah. Right. Right. All right. You're raising a really important issue. Okay, okay, this is complicated and it's really important and you really need to know this, okay? There's treatment as studied, and then there's versions of the treatment that have not been studied. Mentalization as studied is a very intensive daily outpatient treatment program for a long time, followed by fairly intensive outpatient treatment for longer. There are lots of versions in this country of mentalization. There are now current adaptations of mentalization, which are ordinary outpatient programs. There are no data yet about mentalization as an ordinary outpatient. We don't know if mentalization twice a week works anything like the mentalization from the studies, which is daily for 1.5 years and then twice a week for another 1.5 years. We don't know. It might be just as good. It might be better. Could be better. I mean, who knows? But it's not. This is a problem. Bateman and Fonagy are good researchers. They're decent people. but they also developed a treatment program that worked really well that was not exportable. It was too expensive, okay? 5 days a week for a year and a half. In the United States, nobody's going to pay for that. Not up front. Not that I'm aware of. So the versions that get implemented in the United States, and frankly the versions that are getting implemented in the UK now, are smaller versions. And actually we don't have a randomized trial for those versions. It's a huge jump in assumption to say that that's true. In DBT we have something of a similar problem, except it's halfway solved, okay? In DBT is a complex program where people get individual treatment and skills training, typically in groups, and there's a consultation team, and then there's the opportunity to get between session coaching on skills, and ideally, at least in my mind, also family interventions. Okay, so it's 5 different parts to DBT. The research has evaluated that, the complete package. When people say they're doing DBT and they're only offering skill training programs, in DBT we've been very clear, we can't call that DBT. You can call that skill training, you can call it a skill group, that's fine. It may be helpful, there's actually evidence that it's helpful. There's also evidence that it's not nearly as helpful as the entire treatment package. So we've kind of solved that and actually working towards being able to accredit whole programs that are offering the package that has the evidence, as opposed to a piece of the package where we don't know what it's doing. We don't know if it's as effective as the whole package. So DBT, now DBT is 15 years ahead of mentalization in terms of research. How long people have been doing research on? Well, 10 years ahead. So, I mean, who knows? So I want to be clear, this is just about the data. I actually think, I want mentalization, honestly, I want mentalization to work. I want it to work really well because there's more opportunities for patients if there are more treatments that work. So I have no dog in the like DBT banner. I mean, I don't think I'm going to be out of a job anytime soon, but I'm very happy to have many other treatments that work really well for our patients because one size is never going to fit all.
Actually, I have a question for you, Alan.
Yep.
Oftentimes nowadays, parents ask us for resources.
Yep.
And in certain locations, there are DBT programs for the most there are not. But there are more and more clinicians who practice, they call it DBT informed.
Yep.
What would be a good sort of formal resource that they have to that for?
Okay, that's a great question. So what about when formal DBT isn't available or formal mentalization isn't available, but you've got a therapist who's got some training in that and is doing a treatment that's informed by those principles and practices. Okay, so actually let's look at the next 2 items on the list here. There's treatment as usual and specialty treatment, okay? Treatment as usual means that it's a treatment, it's a generic mental health intervention, okay, like cognitive behavior therapy, or psychodynamic therapy, or supportive psychotherapy, or, you know, fill in the blank kind of therapy. Now, I don't want to poo-poo those, okay, because there are many people for whom those, many people for whom those kinds of treatments are very helpful. But for this population of severely dysregulated people, every single study that's compared a specialty treatment to treatment as usual, a treatment that's specifically for people with severe emotion dysregulation, suicidality, self-harm, dysregulation, every study has shown that the specialty treatment works better than general treatment, treatment as usual, non-specific treatment. This is really important. And then, by the way, just to go a step further, that's also true for other problems. If you look at, for example, depression treatments work better for depression than generic treatments, okay? Panic disorder treatment works 90+% of the time for panic disorder. Generic treatments work about 20% of the time for panic disorder. There's a huge difference between specialty treatments and general treatments, okay? The problem with borderline personality disorder, severe emotion dysregulation, is that people meet the criteria for 5 or 6 or 7 diagnoses, okay? So you might argue there is no specialty treatment. You know, we treat the depression part with depression treatment, we treat the anxiety part with anxiety, we treat the eating disorder. No. That's the whole point of having a multi-problem emotion dysregulation specific treatment. That is a specific treatment for multi-problem people who are dysregulated. DBT, mentalization are specialty treatments. Okay, does that make sense? So if you've got a practitioner in your neighborhood who, I would say there are two criteria to help answer that question. One is who really likes working with people who have those kinds of problems. Notice what I said, who likes these people, okay? Psychiatrist in town where I live who says, I don't need to do an interview. I can tell a borderline person when they walk into my office because the hair stands up on the back of my neck. Ouch, you know? I mean, now that's of course wrong. Of course she can't do that. Somebody she doesn't like, you know, she's anxious about, is telling her that the person has borderline. That's ridiculous. It's pejorative, it's judgmental, it's not true. She's unyielding in her opinion. I haven't changed it. I've been working on it for 15 years. I haven't changed her opinion on this. But she's softened a little. But needless to say, I actually don't send our folks to her, okay? Because I don't think she really likes people with these kinds of problems. It's a big world. This is actually, I bring this up because I like the psychiatrist in every other way, and she's very good with other kinds of problems. She stinks with these kinds of people because she doesn't like them. Nobody wants, I mean, even your dentist could be if your dentist doesn't like you, do you like your dentist? I mean, you know, come on, be serious. So the short answer is two parts. One is that they really like working with people with these problems, borderline personality disorder, if you will, emotionally dysregulated people, suicidal, whatever you want to call it, and they do have a specific treatment they're trying to use. They have specific, borderline-specific, suicide-specific treatment that they're trying to use. That would be better than, the evidence would tell us that would be better than the alternatives available. Probably not as good as DBT. Okay, for example, we have a study in DBT showing, comparing experts in treating BPD, real experts, but non-behavioral, non-DBT experts compared to ordinary DBT therapists, and the patients getting DBT did better. And again, the patients getting expert non-DBT did pretty darn well. This was not a bad treatment, but it wasn't as good as DBT. DBT, you know, so it's not like they're all equal, but boy, if I had a loved one, I'd much rather them get treatment from a BPD expert than somebody else, unless DBT or maybe soon, maybe mentalization. I really want the mentalization folks to do some research on the current version of it because it's such an open question whether it's going to look the same. We just don't know. Yeah. Yeah. What is the frequency? The good news is that the DBT has been evaluated as an ordinary outpatient program where people come in once a week for individual treatment and once a week for a skills training group, plus have some between session coaching opportunities. That's the standard outpatient model for DBT, and there are many studies for that. DBT has also been evaluated in day treatment settings where they come in every day. It's been evaluated in residential treatment, 90-day treatment program for adults, for example, 6-month programs, 1-month program, 3-month program, 6-month programs for teenagers. It's been evaluated in forensic settings, in prisons. So it's actually been evaluated in the ordinary places that people get treatment. It's been around long enough, and almost all of these studies are not by Marshall Linehan. There are other people studying DBT, so there's some objectivity to it. You know, and these kinds of studies are now going on with mentalization too, and in 10 years we'll have a much better sense of mentalization's applicability. Mentalization may turn out to be just as good. The data so far don't suggest it's better, but the data suggests it might be just as good. At least it's in intensive form. We just don't know about its less intensive form. You're going to get lots of questions, so this is your time to ask them, because these are, family members are very interested in this information. And it changes all the time. So this is the section that I update regularly. Yeah.
Is there a class that we can take as parents on DBT that would, you know, there like a 3-day version of it that we could take just understand it more about it? I've been told that training, those skills are good for anybody, in any
Yeah.
situation. So is there something available for us without borderline?
That's a great question. It depends on where you live and whether you're willing to travel. There are all kinds of training available in DBT, and many of those trainings would allow non-therapists to attend. And it may be that if there's a DBT program in your community, that you could convince them to offer a DBT skills training program for parents and loved ones. That's entirely possible. We do, in our clinic, we do a family connections program, and then we also have our family connections program on steroids, you know. So we do family connections, and then we do plus. We go on to do a kind of skill boot camp afterwards for people who want to. So, but for example, like, you know, when I do a 2-day training for therapists in DBT skills, I would always welcome family members to attend that. That would never bother me. There's nothing that would go on there that I wouldn't be happy for family members to come to if they wanted to. Some of it's a little bit inside baseball because it's targeted for therapists, but I can't imagine more than 2% of it would be out, you know, outside the range of what we 98% comprehensible. It's not really rocket science. It's emotion science. And we don't all have rockets, but we all have emotions. Yeah. Who's got the microphone? Where's the voice is coming from somewhere.
That in response to the question,
Yeah.
just like you asked, a colleague and I created something that we put together called DBT Just the Basics.
Yeah.
Not for doing a full diary card and individual patients,
Mhm.
but simply because so many, just as you're doing here in this, emotion regulation skills and stress tolerance skills are really valuable.
Mm-hmm.
So we created not really watered down, but a very more accessible, like
Yeah.
just the basics in the sense of taking pathology and
Right.
etiology out of it and simply a skills training without going through any of that,
Right.
just to give people more tools.
Absolutely.
And I don't know, like on feedback, I haven't seen that. We just did it as a way to
Right.
try to fulfill that need.
Yeah, I haven't seen a lot of it for families. Yeah.
I don't think that's a rational model.
Right. No, I think that's right. And Perry, you know, Perry has organized, NEA has organized conferences around the country that often do a baby version of this, where there's somebody spending a half a day teaching about what mentalization is and a half a day teaching what DBT is for family members, not for professionals. Professionals can go to that too, but it would be geared for families. If these are the kinds of things you think there'd be a broad audience for, talk to Perry. We can always do another conference. I mean, if you think that there's interest in a day, 2-day, or a weekend DBT skills for parents, you know, I'll come and do it. I mean, somebody will do it. I mean, it doesn't have to be me. Oh no, you'll be so tired of listening to me. You'll want somebody else. But it won't be hard to find somebody who'd be happy to do that. Yeah, Gabrielle, where's the microphone? Where's our Gabrielle? Oh, sorry. Yeah. Right. 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 So there's two sides of this. One is if you've got a patient, how do you get the family members to participate in something? And you also, like, if you've got family members, how do you get the patient to go into treatment? And they're both good questions. So I think if you're the therapist, you've got the opportunity to appeal to the family members' well-being for themselves. Lots of times, let me ask family members in the room, have you ever felt blamed and judged by a mental health professional? Okay. So I just want therapists there, I want you to notice how there was no latency in that response, okay? I want you to notice it. So what that means is, and I know many of the you therapists there, it's not you, okay, that's doing that, okay? I know that. But there are many people who do. And so when people have had that experience of being blamed and judged, and then the idea is, oh, come on in, join us, we want to have a family session, it's like, not again. And so what's really important for therapists is to be validating and call them up on the phone and say, look, you know, what kind of experiences have you had with the mental health system? And say, you know, I just want to be clear, that's not what we're going to do. I suspect that it's not easy for you to be a family member. And, you know, we're working with your child, with your partner, and, you know, I hear lots of this. I hear, you know, not complaints about you. That's not why I'm calling you. I'm calling you because I think that your family is suffering, and I think we have some tools that could help you just for your own sake, which in turn is not going to be unhelpful to my patient, but would also be helpful. But it's a both and. This is helpful for you. I'm not trying to sacrifice you for the patient. And in my experience, that when you get clear that this is for the family member, family members become much more interested. Who wants to go to a session of being blamed? You know, this is like, wow, I could think of, like, I could sit and pull my fingernails out for an hour. That would, you know, I could do that at home. So that's a piece of it. And also, sometimes people just don't want to. And you can't make them. But you can, again, create the opportunity and encourage and cajole, and that's all we can do. We'll talk later, because sometimes for family members, the other problem is there, like my loved one won't go to treatment. And what can you do about that? And the answer is not much. You can create small opportunities, but you can't even do, as a family member, you have less that you can do than a therapist can. A therapist has more to do with a family member they've never met than you do with your family member that you deal with all day. It's just one of those things in the world. So there's not that much we can do, but we'll talk about that a little if you want to later. Okay, so treatment is complex and important. Yeah. Oh, sorry. Right, exactly. Okay. Other questions about treatment? I'm a little surprised. Usually by this point somebody's brought up medication. I'm happy, believe me, I'm happy not to talk about medication. But I'm also happy to answer questions if I can. Yeah, fine. Dinah? Yeah? Okay, we'll get you the microphone here.
My daughter is one of the
Yeah.
and
Okay, we're gonna let's make our lives complicated now. Okay, so let me talk. I don't have the slightest idea whether that's a useful medicine for your daughter. I just don't know. Let me be clear though, that the little piece at the end that you said for borderline, there is no medicine that treats borderline personality disorder. Okay, there is no medicine that treats borderline personality disorder. That's not me, that's the Federal Drug Administration. Okay, there has not been a medicine that's been approved for use to treat borderline personality disorder. That doesn't mean that our folks shouldn't be on medicine. It just means that we're not treating the disorder. Let's think about treatment. Think about treatment in two different ways. And I think we use the word treatment when we talk about medicine.
Chemical medicine,
To treat, there's no medication for borderline personality disorder. None. None. That doesn't mean that there aren't medicines that treat component parts, okay? But I'll come back to that in just a second. Let me just be clear that there are two ways that we use the word treatment. When we talk about psychotherapy, you have the idea, you know, if you're treating somebody in psychotherapy who's depressed, you have the idea that there's one outcome that you want. What's that? Not be depressed, right? That's very clear. If you're treating somebody with diabetes, what outcome do you want with insulin? Right. And the expectation is that the person is going to be on the insulin forever, probably, okay? It's also possible that they could, some people anyway, for diet and exercise might not need the insulin anymore, okay? That's a different kind of treatment, diet and exercise, where you no longer need the insulin, then the insulin regulates and you continue to need the insulin, right? You take an antibiotic for pneumonia, the expectation is that you will no longer have pneumonia and you won't have to keep taking the medicine, right? The antibiotic you'll run its course, pneumonia is gone. So there's two kinds. There's a maintenance treatment which results in healthy functioning, and there's a treatment which isn't maintenance, it isn't continued, but it results in healthy functioning. Those are two kinds of terms for it, right? And there is no medicine that does either of those for BPD, okay? Now, people with BPD also have multiple other diagnoses, and there may be medicines that help treat some of those sub-problems. So for example, for some patients who are, and by the way, 85% of people with borderline personality also in and out of being depressed, not 100% of the time, but get depressed, maybe less depressed, more depressed. And for some proportion of those, it's hard to say, but maybe half, maybe less, but something like that, antidepressants can be helpful to reduce depression. But reducing depression does not take away borderline personality disorder, although it might reduce their risk of a suicide attempt. So it's not trivial, and it's not a bad thing. If that's helpful, we want people to be on those medicines. Now, it's also possible that that's a maintenance, that if you stop taking the antidepressant, that person would get more depressed again. It's also possible that they wouldn't. It's hard to know. Depression is very controversial. We know that the relapse rate when people, even talking about non-borderline now, just depressed people, when they stop taking antidepressant medication, relapse rates are very high. For some people, they don't relapse, but many, many do, more than half, suggesting that the depression model of treatment with antidepressants is probably a little bit more like the insulin diabetes model than it is the pneumonia model, at least for most people. However, the data also tell us that if you stay on antidepressants long enough, for a subset of people, not a trivial number, they stop working. So unlike insulin, where it keeps working, okay, almost all the time. So this medication thing is complicated. Now, what we do know, what we have learned is that medication, the treatments for borderline personality disorder, say DBT, that at the end of DBT, patients in DBT who have succeeded in DBT, meaning they're doing well, are on significantly fewer medicines than people who are not doing well, okay? Now that's a really complicated statement that we don't 100% understand. It may be that the DBT is helping them psychologically do so much better that they don't need medicine, or it may be that it's helping them do enough better that other people aren't so scared and so they discontinue medicine. Maybe just that other people don't need it either, but they're reluctant to remove them if they're still dangerous. Or it might mean that DBT is just better at getting people off medicines they don't need. And actually, there's an iatrogenic effect of actually being on there's such a thing as too many medicines for some people. Now, I have to say as a clinician, this varies from city to city and region to region, so I'm not trying to make a general statement at all. But in my city, people who make suicide attempts scare the poor doc who's in the emergency room. They scare him or her. I completely get that. I would be scared too if I were in their position. And in the ER, in the middle of the night, there's really not much you can do. You can put the person in the hospital, you can write them a prescription. And if they aren't hospitalizable, don't need to be in the hospital according to that, the only thing you can do is send them away with a prescription. Most people who come to my program, my DBT program, come in on 7, 8, 10 psychotropic medications. And there isn't anybody I know as a psychiatrist, including the people who are prescribing those, who think that's a good idea. Okay? So it's not like somebody saying, no, this is the right set of meds for your daughter, is to be on 9 psychoactive medicines. I've yet, even the person who wrote the 9th prescription would not say, I think that these 9 prescriptions is the right treatment, okay? It's just that I think this person needed this. I would take them off these 4, but somebody else prescribed them, and they're reluctant to take them off those 4. And so they sometimes come into my office drooling and shuffling because they're so heavily sedated. I had a session with a client 2 weeks ago, and when she came in for her follow-up visit, she did not remember that she'd met me the previous week, and we spent an hour and a half together. Okay? Now, I'm not saying that's normal. That's normal in Reno, okay? Maybe we're a backwater, I don't know, but it's normal for us. So medication is a complicated issue, and I want to say that sometimes it's very important to get people on medicines that are helpful. Sometimes it's extremely important to do that, and sometimes it's extremely important to get people off medicines that aren't helpful, that might even be making things worse. And it takes competent psychiatry to do that, specialty care. Your average GP, no offense to them, they may care a lot, and even your average psychiatrist who doesn't specialize in borderline is probably not the best person to do that. So, yeah, now we'll hear from a psychiatrist.
I happen to specialize in borderline.
So I'm making you work, yeah.
Just to speak to your question about Risperdal in general, I didn't know how many people here are aware of this trend now of using antipsychotics as mood stabilizers. There might be some people that aren't aware that that's a trend.
It's a huge trend without any data.
So if you're thinking that a patient is emotionally dysregulated, you conflate that in your head with emotionally unstable mood variability. We want to stabilize it. We put on a mood stabilizer. And the fact that anybody would want to commit suicide, they're crazy, so we'll put in an antipsychotic on top
Right.
of it. So it's kind of irrational medicine, but unfortunately it actually works sometimes. And so then that encourages the practice because you have fewer M's in your practice than you do in supervised studies.
Right. Well, the problem is, and I don't want to...
It works a few times. You
Right.
kind of want to do it with everybody.
Right. But it's hard without controlled studies to know whether that works a few times. Actually, is the medicine working, or removal of a different medicine that's working? It's very hard. It's you know, the related problem here that we haven't quite mentioned is the problem of misdiagnosis. We did a study in my clinic. Again, none of you are going to want to ever visit Reno, Nevada after you hear this. But I suspect that it's not different in New York. I suspect this is not different in LA. Our referrals, people know about it. Our program, I've been running our DBT program now for almost 18 years, and we're the only outpatient DBT program in town, and we treat adolescents and adults. So we get referrals from all over, and we're well known. People know what we do. They know we're the DBT borderline clinic, self-harm, suicide, that's what we do. So we just did a little study, and we found out that, you know, over the course of 5 years, 100% of people who were referred to us had been diagnosed, brought with them a diagnosis of bipolar disorder. We did SCIDs, okay, structured clinical interviews for the DSM. I run a training program, so I can make my graduate students do this stuff. We did SCIDs on all of them in that entire 5-year period, 1.5. One person clearly met the criteria for bipolar disorder. The other was maybe, not clear. Nobody else did. In 100% of people referred to us, somebody had said was bipolar. Okay. Now, the problem is this is not a wholesale critique of the system. I actually am totally sympathetic to the poor person who's giving that diagnosis, because in a crisis, in the middle of a crisis, I'm willing to bet those same people answered yes to all the questions around those criteria. I'm willing to bet that. The problem is with the criteria. The criteria don't say you have to actually do this interview when the person's regulated. Okay? It doesn't say that. Now, you're supposed to know that, and you're supposed to get collateral information, but again, you're in the ER, you've got 12 minutes. What do? You ask the patient. There's nobody else to ask. You schedule a follow-up, they don't show up. They carry the diagnosis with them forever. Bipolar disorder deferred becomes bipolar disorder when it's still there 2 years later. Okay, this is a huge problem because it then lends itself to mistreatment because of misdiagnosis. There are medicines and things that work for bipolar disorder that, why would they work for something else? So anyway, this is not designed to be hopeless. I don't mean to be hopeless. I simply mean to say you've got to find professionals who specialize in this, who follow evidence-based practices. The American Psychiatric Association has an algorithm for medication for borderline personality disorder, which is good because it's based on evidence about the subcluster of problems that you're trying to treat. And it's absolutely essential. What it says is you try this, if it doesn't work, you remove it, and then you do something different, not you add. Sometimes you add. There are times when adding makes sense, when there's evidence that you can augment something. There are times when that's appropriate medically, but there are many times when they're not related, and actually, nobody understands the drug interactions of 7 medications. Nobody understands that. So it's very hard to know. So again, I don't want to be, I certainly mean no offense to anybody, but for family members, Marie Paul's question was, where do you send them? Send them to somebody who really practices evidence-based practice, who doesn't think that necessarily more is better, and is willing to collaborate with the treatment team, whether it's DBT or mentalization or somebody else, to actually make this work the best way that it can. Yep.
Yes, I have a 20-year-old daughter, borderline, and she's been her baby 4 months ago. Wondering, is there any research on young adults that are
There is. Very little, but there is. Actually, it's a pretty good study that came out this year. As you might expect, there are more problems in general with borderline mothers, but it also turns out to be a very heterogeneous group. Okay, so some of the moms in this group are doing an extremely good job, absolutely normal, and others are having more problems. What hasn't been done, and the reason I want you to be very careful around this, is all the studies compare borderline moms to healthy moms. What we don't know is it actually any more problematic for the kid if the mom has borderline personality disorder as opposed to, say, being clinically depressed. Clinical depression is, of course, so much more rampant than BPD. And actually, there are significant problems in parenting with depression, for example. So I think we have to be very careful, A, not to assume that because somebody has BPD that they're a bad parent, because the data don't say that. They say there's a greater risk for it, absolutely. Yeah, but actually we also don't know that it's any different risk than you'd have if you were a person who had a history of depression or anxiety disorders or substance use disorders or eating disorders. We don't really know. So it's actually not as horrific. Up until recently, there's just been a lot of commentary about this with the assumption that somebody with BPD would be a terrible parent. In fact, there are books about that, by children whose parents had BPD who really suffered. And I want to be clear that in some cases that would be real suffering, And in some cases, you have the person who didn't write the book because they never knew, because they got good parenting and it worked out really well. We don't know how to sort those, but we do know that it's by no means a clear prediction that there's a problem. Yeah. Let's wait for the mic. Hang on a second.
I'm very involved sometimes with parents who have kids really, all diagnosed with bipolar, everyone.
Yeah.
And, this is very questionable. And some of the clinicians have a tendency of using that because they don't know enough about bipolar. So I question everyone I talk to, every parent with that diagnosis, and I say, maybe something else too. The other thing is, and Kelly mentioned, is that I'm very interested, and there is a program on, I think it's out of Temple University,
Absolutely. This is one of many problems when any of us has struggles with any kind of disorder that challenges our ability to do anything in our life well. And, you know, it's an issue if our patients have children with their parenting, our patients have parents in their family relationship, our patients have partners in their romantic relationship. These are across the board. All right, so what do I want to do now? Now, I want to say, we're going to talk about this transactional model part. I don't think we have time to do this before lunch. Is anybody hungry? Yes. So I can't possibly do the next 2 slides in less than 20 minutes. So let's stop. Let's have lunch. Does anybody have any questions about the part that we're finishing now? Anybody questions about treatment in particular? Any treatment questions? Going once, going twice. Yes. Whoo, he made it in under the hammer.
I just want to make a comment because I think this is important in terms of bipolar diagnosis and borderline personality disorder. Because one of the reasons I think that bipolar is in there, I think oftentimes when you look at therapy, people look at economics. And I have had very, very few, I can't give any examples where insurance, even Medicaid, will pay for treatment of borderline personality disorder. They will pay for it. That's all.
They'll pay for other disorders, right? That's absolutely true.
But
Yeah.
taxes,
Yeah. You can't. If you just list BPD, a very good chance you won't get reimbursed. Yeah.
and so to an extent, it may be, well, there are some questions as to whether this is bipolar or not. Unfortunately, the trigger may be pulled in terms of someone writing a diagnosis.
Right.
But if we want to do treatment, we may need to say, well, there's a legal rule out here for as far as bipolar, because otherwise it is borderline. Insurance companies say, well, there's
Right.
no treatment.
Right. I completely get the economic drive. My own preference would be for clinicians to look, if somebody has borderline, they have on average anywhere from 3 to 6, 7 other diagnoses. Make them accurate. Get reimbursed for something that's accurate. About 1% of the population has bipolar 1 disorder, about 1% of the population. And there's no evidence that it disproportionately overlaps with borderline personality disorder. It actually probably has a quite different etiology. Its causes are probably completely different, much more biologically driven. It just doesn't overlap. Maybe 1% of people with borderline personality, 1, 2, 3%, would have bipolar 1 disorder. That's it. We wouldn't expect more. Maybe a little more for reasons that we won't have to go into, but it's not the 100% that we find in our clinic, which isn't accurate, of course. It's very seldom. It also speaks to the issue of of misdiagnosis. I want to talk about money, and I don't want to get into this, but bipolar is currently the diagnosis du jour because there are newer medicines and pharmacotherapy, the pharmaceutical industry pushes, and and I want to point out that it's probably not your expert psychiatrists in BPD who are making those misdiagnoses. It's probably not them. It's primary care docs. No offense to them, they have a tough job, but you can't be an expert in everything. And it's even general psychiatrists who seldom see borderline patients who can make big mistakes in that. So it's just a tricky thing. Yeah, Nina.
And I don't know if people are aware that coming next year, the DSM-5 is coming out, and they're off on what that's going to mean.
Yeah, the DSM-5 is coming out. That's going to change a lot, but it's not going to change BPD. BPD is going to stay the same. There was almost a civil war around this, which we don't have to talk about. But for the next foreseeable future, the BPD is going to stay the same in the DSM. That was decided last week, actually. All right, so let's. Past president of the American Psychiatric Association. All right, so let's have lunch.